So, a very good afternoon to all of you. The next CCR will be presented by Department of Obstetrics and Gynaecology and Unit 3. This is a very interesting topic which epitomizes the multidisciplinary management of a young girl. And for this, I would like to invite Professor Rita Mahe and the team, and I would like to invite Dr. Yakvi SR to first begin with the case. Good afternoon, everyone. So, beginning with the case presentation, 30-year-old nulliparous woman presented to gynecological OPD in May 2024 with complaints of inability to conceive since past 2 years. She was referred to us from pediatric and adolescent endocrinology clinic for fertility treatment. On past history, she was under follow-up in endocrinology since 15 years of age. She had come with complaints of not attained menarche, no history of cyclical abdominal pain, with history of underdeveloped secondary sexual characters, and history of failure to gain weight in short stature. However, there is no history of any chronic illness, weight loss, headache, blurring of vision, galactoria, any brain surgery, radiation exposure or chemotherapy, any past exposure to tuberculosis, or any decreased sense of smell. The patient had two siblings, and both of them were of normal height with normal pubertal developments, and there was no such similar history in the family members. On treatment history, she was under follow-up with endocrinology since 15 years of age, where she presented with the following complaints: failure to thrive, short stature, primary amenorrhea with underdeveloped secondary sexual characters. On examination, she had a height of 142 centimeters with weight of 28 kg, making a BMI of 13.8 kg per meter square. Her thyroid was normal on examination. The breast development was standard stage 1, however, there was no galactoria. There was scanty axillary hair and Tanner 1 pubic hair. On local examination, the external genitalia was normal and there was no stigmata of Turner syndrome or dysmorphism. With this history examination, her baseline investigations were done, which included CBC, FSH, LH, TSH, and prolactin, which reported that there was no FSH and LH, however, the TSH and prolactin were normal. With this examination findings and laboratory investigations, two differentials were made, which were constitutional delayed growth in puberty or hypogonadotropic hypogonadism, which could either have been congenital or functional as in secondary to any other cause. To further differentiate between CDGP and congenital hypogonadotropic hypogonadism, a GnRH analog stimulation test was done in which injection decapeptide 100 micrograms subcutaneous was done and LH levels were measured at 0, 2, 4 and 8 hours after injection decapeptide, which revealed that the FSH and LH was still low and hence CDGP was ruled out. Now, the diagnosis was hypogonadotropic hypogonadism, but whether it was congenital or it was functional, to assess that additional set of investigations were done which revealed her CBC, LFT, KFT, celiac disease with IgE testing, and MRI brain was done, which were all normal and hence functional hypogonadotropic hypogonadism was ruled out, making a diagnosis of congenital or idiopathic hypogonadotropic hypogonadism. To further assess the pituitary function, TSH, ACTH, and insulin-like growth factor 1 was done, which were all normal, and hence the patient had isolated or congenital hypogonadotropic hypogonadism with no features of pituitary deficiency. So the plan of management was made, which included puberty induction followed by her cyclical menses, and then future reproductive outcomes. Puberty induction, she was started on tab estradiol valeric 1 mg every alternate day for 6 months, and which was gradually increased to 1 mg once daily for 6 months, and then to the adult dose of 2 mg once daily. So, estrogen therapy was given for a total duration of 13 months, and during this 13 months of unopposed estrogen treatment, her secondary sexual characters were developed from Tanner stage 1 to Tanner stage 4. And however, she had no breakthrough bleeding in this entire 13-month period. And hence, the estrogen treatment was continued for a total of 24 months. During this estrogen treatment for 24 months, the patient also had gain in height. Her baseline height was 142 centimeters, as is depicted in this graph. It has initially increased for the 11 months with only calcium and vitamin D3 supplementation. And then further, a total gain in height was of 13 centimeters with the help of estrogen therapy. As depicted in the picture, the final height of our index patient was 162.5 centimeters. Then she was put on cyclical estrogen and progesterone, which included tab estradiol validate 2-MGOD from day 5 to 25, and tab hydroxyprogesterone acetate day 10 of 10 MGOD from day 15 to day 25 for cyclical menses. Now, with this, she was counseled by the endocrinology that she might be needing ART for future fertility, and hence was referred to OBGYN department with the same. So when she came to us, a detailed history and examination was done, but unfortunately, the patient did not give consent for any gynecological examination despite being married for 2 years. On further probation, it was revealed that couple had not consummated their marriage as there was significant psychological distress and anxiety in the patient. Couple did not want any treatment for sexual dysfunction, and their only concern was to achieve pregnancy. So her hormonal pills were stopped and baseline infertility workup was advised. AMH was on the lower side of the normal. TSH, prolactin, and HSA though were normal. Despite all investigations being on the normal side of the special concerns in this case were that the patient was diagnosed with congenital hypogonadotropic hypogonadism since adolescence, and it was associated with significant psychosocial stress in the patient, which has also led to non-consummation of marriage. And the diagnosis, the psychosocial stress was to the extent that the diagnosis was not revealed to anybody in the family apart from the husband. So she was not willing for any treatment for sexual dysfunction, and the couple was wanting to go directly for fertility treatment, but with no vaginal manipulation. Couple counseling was done, and fertility options were discussed with the couple. The couple was referred to psychiatry department for counseling and evaluation, though they did not agree to do same. So the options given with this background in history and the associated psychosocial distress with the patients were diagnostic hysteroscopy, laparoscopy, followed chromoperturbation as tubal factor could not be assessed by HSG as we routinely do in infertile patients, followed by OVI, IUI, or directly IUI. But the concern with OVI, IUI was since the patient did not want any vaginal manipulation, so each cycle of IUI would have required anesthesia, which would have increased risk to the patient. So the couple directly opted for IVF, but with all vaginal manipulations to be done under anesthesia. So the patient was recruited for IVF and was started on HMG 300 international units for a total days of 13 days, making a total dose of 4,650 international units. Follicle monitoring usually is done by TVS in IVF cycles, but since the patient did not want any vaginal manipulation, it was done by a transabdominal ultrasound, which was again a challenge, and the patient was followed up by hormone profile. Injection recombinant HCG 250 microgram trigger was given when 3 follicles of size more than 17 mm were seen. Total 4 oocytes were retrieved by transvaginal route. IVF was done with husband semen, and 3 day 2 embryos were formed. On 2 embryos were transferred, and UPT was positive on day 16. The patient was booked at AIIMS during first trimester, and progesterone support was given throughout the first trimester. Routine antenatal care was given to the patient, and luckily the antenatal period was uneventful, and then now she's delivered a healthy baby boy weighing to 895 grams. Now the further discussion will be presented by Professor Rita Mahema.
Thank you, Yashvi. Okay. Just to start with the delayed puberty, so which is a constitutional delay of growth and puberty. It is a common disorder which we see mostly by the pediatric colleagues, and these patients present with delayed puberty and delayed growth spurts, but these are usually transient, and ultimately all of these adolescent girls, they eventually attain puberty and the cycle is completed spontaneously. But what is the diagnostic dilemma? So whether if the child is presenting with delayed puberty, so whether it is just constitutional delay or it is some underlying pathology which is because of hypogonadotropic hypogonadism, the problem is at the hypothalamus pituitary, or it is because of gonadal failure or some other causes. So why this diagnostic dilemma is important? We need to investigate these girls because in if it is not CDGP, we need to start the treatment as early whenever they are presenting in adolescent. So coming to hypogonadotropic hypogonadism, as we all know, so this is a functional, mostly these cases are functional and they are secondary to some cause because these adolescents usually they reduce too much weight because of anorexia nervosa or they are athletes or because of disturbed dietary habits. So they lead into acquired hypogonadotropic hypogonadism and they present with amenorrhea. But the problem is with congenital, which is a rare disorder as compared to the secondary one. So when the child is presenting with delayed puberty and failure to thrive, like our index case, she presented in adolescent age with primary amenorrhea. So mostly the clinical picture is same, but we need to differentiate whether it is just constitutional or CHH, as it was done very nicely by our endocrinology colleagues. So she was given the GNR checklist challenge test, and in this case, if the LH is not rising, it stays low, it means there is no pituitary activity, so which confirms the diagnosis of CHH. So in these patients, the treatment should be started as early as possible whenever they are starting in the adolescent period. So just to summarize that if a child is presenting with delayed puberty or normal pubertal development and the basic simple test, this she should not be sent back. The basic hormonal test, FSH and LH and bone age. So these are the three tests which can differentiate and to try the patient if they are suffering from CHH so that timely therapy can be started. So this condition is comparatively rare because of complete absence of these hormones from the hypothalamus. Incidence is less than 10 per 100,000 births, and it is a diagnosis of exclusion. And because in all these cases we have to exclude whether the child is suffering from constitutional delay or he is suffering from this congenital one. And most of these patients are actually the Kalaman syndrome, and which may or may not be associated with anosmia. So more exact genetic this transmission is exactly not known. Mostly these patients have whatever the literature is there, they are reported mostly in the men who present with delayed pubertal and growth spurt, but the incidence in female is comparatively less. So because most of the literature is presented in the adolescent boys, there is actually the paucity of literature about this condition in adolescent girls and what is the effect of this problem on the future fertility and pregnancy. So, what are the challenges? So, first is the diagnosis, as we discussed, then is puberty induction, so which was timely given to our index case. She was given treatment in time so that she had growth spurt, and then she was given cyclical hormonal therapy so that she gets cyclical menses, and then she was referred to us for fertility treatment. So it is very important that we timely diagnose and treat these patients because they have there is a risk of associated deficiencies because of estrogen deficiency in the body, which can lead to calcium deficiency and accelerated osteoporosis in these adolescent girls. And then the psychosocial impact of the disease, like our index case, she had the impact was so much that she did not allow any vaginal manipulation. She actually, when she entered first time to the OPD, when the resident went to examine her, she started crying and crying and crying. So she had that crying spells for almost half an hour. Then she revealed the history that so that is not our primary concern. Our primary concern is only that we want a child, and luckily she had the supportive husband so who has been supporting, but none in the her in-laws family knows that she is suffering from this disease. So we need to understand the social challenges also in these patients, and then once the pregnancy is achieved, then they need long-term HRT also till the age of 45 to 50 years. So it is the timely diagnosis and treatment is important so that we keep them under follow-up, like our index case, and multidisciplinary setting treatment is required. And because diagnostic delays can lead to poor outcome in their fertility treatment also, and this can adversely affect their physical, psychological, and fertility implication. So, like we noted a case that, and it's not very common. Like whenever these patients come, young patient coming with primary amenorrhea. So mostly the residents normally we think that every this primary amenorrhea will have absent uterus, so which is MRKS syndrome. So because these patients they have no estrogen in their body, so their uterus is so hypoplastic that it is not even visible on ultrasound. And as they are presenting in the adolescent age, we cannot do transvaginal scan. So transabdominal ultrasound can even miss this such tiny uterus. So they are mislabeled as cases of absent uterus or MRKH syndrome. So like this patient, she was sent back that you are she's MRKS syndrome with no uterus, and but later on when she presented again at 27 years, so that after marriage, then the transvaginal scan actually noted that she has hypoplastic uterus, but by this time already her DEXA scan showed severe osteoporosis because she was deprived of estrogen for around 15 years when she presented. So we need to keep in mind that uterus may not be visualized in these cases because of lack of estrogen. So it's very important when in OPD we see these patients, detailed examination, imaging, hormonal tests which are very simple and easily available, and most important is interpretation of all these investigation is must for these adolescents presenting with primary amenorrhea. And because our ultimate aim of every woman is actually to get pregnancy, so to prepare the uterus for pregnancy, it's important that we timely start them on therapy. So these patients need multiple people because most of them they present to the general practitioner or pediatricians. So they should be timely referred to adolescent endocrinologist and gynecologist, and timely referred to fertility specialist, and they need genetic counseling also because there is risk of transmission of this disease to the offspring, and at every step they need psychological support also. So all of these play significant role in achieving successful outcomes. So if we see that how CHH is different from the functional one or secondary one, so it is different because in the functional one patient has some amount of hormone. Her HPO axis was actually working, which has stopped now. But in congenital, there is zero levels of FSHL LH. So that is why their ovaries are also totally silent. So and it is difficult to assess their ovarian reserve also when they come to us for ovarian infertility because these AIIMS and antral follicle count they are not even visible on transvaginal scans sometimes because the ovaries are so tiny because they have not received any FSH or LH from the body. So the first thing is that we have to timely start estrogen so that she has adequate breast growth and adequate uterine growth. And then so we can see these patients like the patient who was missed at 15 years and she again came at 27. So this is what the MRI picture they have reported that after giving 1 year of estrogen, so we can actually see, so here because they did not get MRI done, so uterus is almost negligibly seen. So but after 1 year of estrogen therapy, so we can see nicely developed uterus, so which is ready that she can undergo fertility treatments now. So what if the treatment is not delayed? There are case reports on this also that because if they are not started on treatment, they come directly with infertility with mostly wrong diagnosis. So no worry, even if delayed, we should start treatment whenever the diagnosis is made because these are the patients we can give them opportunity to have their own genetic child and with their own without needing surrogate mothers. So estrogen therapy should be started timely whenever they are presenting with amenorrhea. So as we saw, why AIIMS is not reliable. AIIMS is test which we check for ovarian reserve, but in these patients, because most of the follicular line here, because they are not getting FSH and LH, so most of the follicular line in the silent primordial follicle. So AIIMS is not very reliable marker of ovarian reserve. So that is why we these patients are difficult to treat while we are treating for their fertility also because they will require very high doses of gonadotropin to stimulate the ovary and less number of oocytes. Like in our case, only she's a young 30 years old lady, so we got only 4 oocytes and we could get only 2 embryos on day 2. So which is not a very age appropriate number of yield which we will expect from this age group woman. So although these patients, when they come to us for infertility, our standard treatment is that we give them injections and we give IUI intrauterine insemination, or we tell them to try naturally. But the problem in our case, as we discussed, the psychological distress was so much that she did not want any treatment like that. And so we had to explain them about the cost and need of high dose of gonadotropin injections also. So although IVF is done only for specific indication, but in our case we have to change because of the couple issues. So when we reviewed the literature about congenital hypogonadotropic hypogonadism, so we thought it is, so otherwise the data is there, but at CHH, so there are handful of studies, maximum around 400 cases have been reported till date, and the pregnancy rates with either ovulation induction or IVF is around 30 to 50%. So, which is fairly good as compared to the normal ones, but in some cases they have landed up in poor outcome because of the poor response to gonadotropin. So, but and in these data, there is no study from India. So, from India, we could find only one paper where they have done IVF in hypogonadotrophic hypogonadism, but the paper has not mentioned whether it was congenital or secondary. So, we really don't know that what is the exact incidence or prevalence in our patients. So then another one problem is that because there is no hormone in her body, so she might not respond and she will require very high doses. So then it is like we do in boys with delayed puberty or with hypogonadotropic hypogonadism, they are put on LH or HCG injection. So like here also that there is, if the patient is not responding, so we prime them with LH administration for 1 to 2 months before actually starting them on gonadotropins. So this is case report just we saw where this additional treatment before starting the actual IVF has resulted in successful IVF outcome. So to conclude, the message from this case which gives us that not every case of primary amenorrhea is MRK syndrome. So we need to understand the different pathologies. Eyes can't see which if the mind doesn't know. So it is important that we sensitize the clinician about complete evaluation of primary amenorrhea, timely refer to pediatric or adolescent endocrinologist, timely refer to for fertility, psychological support through the treatment and alternative fertility option. So this case was actually very nicely managed by the pediatric endocrinology department under Dr. Rajesh Kadapat. Sir is not here because he had to go somewhere. So we referred the patient to ask for fertility. So we had successful outcome. So to have successful outcomes, so we need to timely puberty induction, estrogen therapy, to have adequate growth of uterus, and understanding the dynamics of patient choices while choosing fertility treatment and to choose the best possible treatment to have best outcome and long-term health also. And this case emphasizes the importance of stepwise treatment of these adolescent girls with congenital hypogonadotropic hypogonadism with multidisciplinary involvement targeting different aspects of health and fertility outcome. Thank you. So this is our patient. So we have delivered 3 days back. Thank you so much.
Very well managed case.
Thank you, ma'am.
And you rightly said that the entire, it was a teamwork actually.
Yes, ma'am.
If the endocrinologist could have not induced the puberty, if not started the insulin at the right time, the uterus would have been very hypoplastic. And it would have not been possible to give her a child because then we had to use very long term. And sometimes endocrinology becomes so refractory if you do not start the estrogen in time that it takes very long time to make this uterus receptive and to make her pregnant.
Yes.
And secondly, that when they induce puberty, you can see the height also.
Yes,
she
ma'am.
was such a dwarf girl.
Yes,
And,
she attained almost 13 centimeter.
Gaining that height at that period is very crucial because if you induce puberty and then you expect that the height will not increase, so you have to gradually increase the estrogen to attain the targeted height and then give her start the period or the progesterone withdrawal, which is very, very beautiful. I think Dr. Rajesh also needs a special mention.
Yes, yes. Sir has actually prepared the patient for us. They referred in May.
Yes.
So, but because of so much couple stress, so we could not wait. We directly recruited her for IVF. So she has delivered just 3-4 days back.
She was not waiting for any vaginal management.
No, ma'am. She entered the OPD because I thought it's a routine case. So the resident went for examination, but suddenly we started screaming sounds from that side. So then we saw, so then she was crying. So then we talked to her. Then she said, no, it's a husband was very supportive. Yes, the husband, yes. We tried to send them to psychiatry also that for counseling and anything, but they did not agree. They said, we don't want anything. We just want pregnancy.
How she tolerated the.
We didn't do any scan, ma'am. We had egg retrieval vaginal. Yes, ma'am. Vaginal and but embryo transfer was also done under anesthesia. Well, IV sedation. So she was very skeptical. She did not want any vaginal manipulation while she is awake. So that is why we had to skip. Yes, ma'am. No, nothing.
For the first transfer time.
Ma'am, she had only 2 embryos, so we did not get very good yield because of maybe because of the underlying pathology. But so she conceived in breast transfer.
Yeah, so I think it is a great teamwork.
Thank you, ma'am.
Very fascinating case in many different ways from the
Yes, sir.
this young couple who consummated their marriage. There are lots of conditions in there, nothing to be done.
Yes, sir.
What about breastfeeding?
So she is breastfeeding. So normally these questions they have, because now the placenta is there, so now the prolactin will start decreasing. So they have good breastfeeding. So she is breastfeeding. Breast is, so that again. I think we should. The endocrinologist has given her this such nice estrogen support when she was adolescent. So she had adequate breast development, because when she presented to them, it was 10 or 1. So she did not have breast growth also. So everything was done timely so that she could have successful outcome, because of the so much psychological disturbance also.
Also, now that we have achieved in terms of having a baby, this might be time to once again speak to them about ways for psychological support. Because at that time,
Yeah, yes.
the mind is closed, they say all you want is a baby. Now that they have it, they might be a little bit more open to the idea of
Yes, sir.
support. So you could try.
Yes, sir, we'll do that. Yes, sir. Yes, sir. Yes, once the breastfeeding is completed, so she completes the lactation. Once the lactation stops, so we'll again put her on cyclical estrogen plus progesterone. Thank you.
PM people, no way. Any other comments from the faculty? Anyone?
Thank you, everyone.
Thank you very much.